Blood gases. For the first part of today's lecture, I'm going to spend some time talking about the chemistry behind acids and bases before we move into how you would use this in a clinical setting or in a laboratory. So I want you to bear with me for about the first 8 or 10 slides, and then from there we're going to do some real-life examples of how we use blood gases in the clinical laboratory. So first, let's look at some definitions. An acid is a substance that can yield a hydrogen ion or hydronium ion when dissolved in water. The pH would be low. When you think of things like stomach acid, that would be a low pH. A base is a substance that can yield hydroxyl ions, or the OH, and would have a high pH. Things that you may have come across in your past that would be basic include baking soda or other things that would have a high pH. We talk about dissociation constants, which is the ionization constant K value, which describes the relative strengths of acids and bases. You'll see pK in the Henderson-Hasselbalch equation, and that is the negative log of an ionization constant and pH in which protonated and unprotonated forms are present in equal concentrations. A buffer is a combination of a weak acid or weak base and its salt. It is a system that resists change in pH. If you think back to when we did some enzymes and enzyme testing, a lot of those have buffers present so there isn't a change in pH. Enzymes are very finicky, and we want to make sure that the pH stays very normal in that system. We talk about the maintenance of hydrogen ions quite a bit. The normal concentration of hydrogen in extracellular body fluid ranges from 36 to 44 nanomoles per liter, but the body produces a much greater quantity of hydrogen. The lungs and the kidneys and the body control and excrete hydrogen to maintain pH homeostasis, or regularity. We like to keep a pH in our body of about 7.40. If somebody has a pH below the reference range of 7.34, then they'd be considered with acidosis. If somebody has a pH above the reference range of greater than 7.44, we consider them to be in alkalosis. We do have buffer systems in the body that help regulate these hydrogen ions. The buffer resists that change in pH. Buffer systems are the body's first line of defense against extreme changes in hydrogen concentration. All buffers consist of a weak acid and its salt or a conjugate base. The bicarbonate carbonic acid system has a low buffering capacity, but it's still important to buffer for these 3 reasons. The hydrogen carbonate dissociates into carbonic acid and water, allowing for the carbonic acid to be eliminated by the lungs and hydrogen as water. Changes in the carbonic acid modify ventilation or respiration rate. Bicarbonate in concentration can be altered by the kidneys as well. Other buffers include a phosphate system and a plasma protein. So we've got 2 systems going on: ventilation, which controls our CO2, which is an acid, and the kidneys, which control our bicarb, which is a basic component, or the major buffering capacity of the body. So here's how the lung and kidneys come into play. In the lungs, ventilation affects the pH of the blood. Oxygen is inspired and diffuses from the alveoli into the blood. CO2 diffuses into the alveoli from the blood and is eliminated via ventilation. The result is a minimal change in hydrogen concentration between the venous and arterial concentrations. So when we have the CO2 buildup in the bloodstream, your body's able to actually hyperventilate to excrete more of it through the lungs. If the pH starts to go up, then we are able to maintain by hypoventilating or not ventilating as fast to bring the pH down. So we can control the amount of CO2, which is acidic, via hyperventilation or hypoventilation in order to increase or decrease the pH. On the same token, the kidneys can regulate acid-base by excreting bicarb. It can either have you urinate out more bicarb, or it can maintain more bicarb to help bring that pH up or down. Now, if the blood is too acidic, having too much CO2. Let's say somebody has emphysema. The kidneys are able to hang on to more bicarb to help buffer that acidic situation and bring the pH closer to normal. Same thing if in the opposite direction. We can actually urinate out more bicarb if we are becoming too alkaline. The assessment of acid-base homeostasis comes from the Henderson-Hasselbalch equation and the bicarbonate buffering system. It uses the measurement of components of bicarbonate buffering system, and it provides information on other buffers and systems that regulate production, retention, and excretion of acids and bases. This equation that you see, pH equals the pK plus the log of acids over bases, is something that we use to calculate pH. Now, this isn't something that I'm going to have you do routinely, but just so you know where pH comes from. When we classify a patient in the hospital with an acid-base disorder, we classify them as one of the four of the following: metabolic acidosis, metabolic alkalosis, respiratory acidosis, or respiratory alkalosis. We consider someone, again, to have acidosis if their pH is less than 7.34 or 7.35. If it's alkalosis, if the pH is greater than 7.45. I have some reference ranges in the yellow screen below. And you see I have a reference range of 7.35 to 7.45. Therefore, if somebody's falling below the 7.35 or 7.34 or below, they're going to be acidic. If they are above 7.45, they would be considered in alkalosis. I have CO2, which is controlled by the lungs, with a reference range of 35 to 45, and bicarb, which is controlled by the kidneys, having a range of 22 to 26. And O2, which is an oxygen pressure of 80 to 110, and an oxygen saturation, which should be greater than 95%. While we don't in the laboratory use a lot of the oxygen, it can give us an indication of how well the patient is breathing, depending on their oxygen. So it can help us to figure out if they're in a respiratory situation or not. All right, so before we get started, I want you to be familiar with Rome. With Rome, you need to remember respiratory opposite, metabolic equal. If somebody has a respiratory issue, their pH and their CO2 would be opposite. I'm going to give you an example in a little while. If the pH is high and the CO2 is low in regards to the reference range, it's a respiratory issue. It's a metabolic issue if the pH and CO2 are equal. So for example, if the pH is high, so is the bicarb. If the pH is low, so is the bicarb. So they run the same direction. Where respiratory, they're going to be opposite. If one's high, the other's low, and vice versa. So let's do an example. If a patient has a pH of 7.20, it is low. So I put a down arrow indicating that it is decreased. They have a CO2 of 75. As we can see by our reference ranges down below, that's very high. So I have an arrow pointing up. Our bicarb of 24 is in the middle of our reference range, so that is normal. We don't need an arrow, it's in the reference range. Well, if we look at our CO2 and our pH, we can see the arrows are pointing in opposite directions. And if we look above, when regards to pH and CO2, if they're opposite, it's a respiratory issue. This person would then have respiratory acidosis. Now let's look at what happens with a patient in a similar situation. This person here starts off with a pH of 7.20, a bicarb of 15, and a CO2 of 40. Her name is Sally Sue, and she was admitted to the immediate care unit with prolonged diarrhea, which is an excessive loss of bicarb. Her blood gases on admission were the following, which I just read: pH of 7.20, bicarb of 15, and CO2 of 40. She's in metabolic acidosis. 2 hours later, diarrhea is still continuing. Her pH is 7.21. Okay, it's a little bit getting closer to normal, but it's still in the acidotic state. Her bicarb is still 15 because she still has that diarrhea, right? And then her CO2 is 30. What she's doing is she's slowing down her respiration and breathing slower to hang on to the CO2. She's not breathing it out. Her body's hanging on to it. So her lungs are starting to save the day. The next day, Sally Sue is in compensated metabolic acidosis. Now, the reason we know it's compensated is that the pH is now within the normal range, but it's still lower. It's still a little acidotic, but it's within the normal range. Bicarb is still 15. She's still dealing with that diarrhea, but now her CO2 has dropped down to help with the pH issue. It's dropping the amount of acid. She's really breathing slowly, and it's allowing the pH to come up to normal range. You don't want your pH to stay in an abnormal range. It is really hard on your organs and things like that. So we're going to take a look at the different types of acidosis and alkalosis and what some of the causes are. A metabolic acidosis is a primary bicarbonate deficit. It can be caused by things like diabetic ketoacidosis, renal disease, prolonged diarrhea, as we just saw with Sally Sue, and salicylate poisoning, which would be taking a lot of aspirin. When somebody's in this scenario, we can see a respiratory fix. In this case, we can have dropping the CO2 through hyperventilation, or we can have some renal issues with reabsorption of bicarb, depending on how well the kidney function is. The lab findings would be a decreased pH and decreased bicarb. Then we have metabolic alkalosis, as seen when somebody has a primary bicarb excess. This is seen with someone who gets a sodium bicarbonate infusion, getting excess anticoagulant and blood transfusions, eating too many antacids. Prolonged vomiting can cause you to lose a lot of hydrochloric acid and therefore have excess bicarb. Potassium depletion, diuretic therapy, and Cushing syndrome. The primary mechanism is hypoventilation, or maintaining the CO2. And you can have some renal. So excretion of bicarb or reabsorption of bicarb, or excretion of hydrogen, reabsorption of bicarb. Our lab findings will be an increased pH with an increased bicarb. Next is respiratory acidosis. This is a primary CO2 excess, buildup of CO2 in the bloodstream. Things that would cause this is having emphysema, where you've got poor gas exchange across the lungs, or pneumonia, or breathing into a paper bag. You may see that in movies sometimes. People are hyperventilating and they'll rebreathe into a bag. The way that the body compensates for being in that situation is having increased hydrogen excretion or bicarb reabsorption. With this, the laboratory findings are a decreased pH with an increased CO2. Respiratory alkalosis. This is a primary CO2 deficit. It's seen in hyperventilation, blowing off too much CO2, having early salicylate poisoning, so when you first overdose on aspirin, it would cause this. And some of the compensatory mechanisms are renal or decreasing hydrogen excretion. The lab findings here are an increased pH or a decreased CO2. Something we don't see as often as the respiratory acidosis. In addition to looking at the acid-base balance, we sometimes look at the oxygen and gas exchange. Nurses and the floor, the doctors, they are administering oxygen and things to patients, so they take a really careful look at this. We do report the oxygen level from the blood gas machine to the physician, so it is very useful for them. But we have to have 7 conditions necessary in order to adequately oxygenate our tissues. First of all, you have to have available atmospheric oxygen. If you go from Wisconsin or Minnesota all the way up to Colorado, the atmospheric oxygen is going to change. So that will go down. You need to have adequate ventilation. You have to have good gas exchange between the lungs and the arterial blood. Loading of O2 onto hemoglobin, as you may learn as you get to hematology, there are some issues there. You need to have adequate hemoglobin. If you're anemic, you're not going to be able to carry as much oxygen. Adequate transport through the body. People with poor circulation are going to have issues. And the release of oxygen to the tissues. And then we have some factors that can affect the amount of O2 as that moves through the alveoli to the blood and then the tissue. Sometimes there's destruction of alveoli, like things like smoking. You can have pulmonary edema, where there's a lot of fluid buildup around the lungs, an airway blockage, having an inadequate blood supply, or diffusion of CO2 and oxygen. There are a few different ways that oxygen is transported through the blood. Blood hemoglobin exists in one of these four conditions. We can have oxyhemoglobin, which we call the O2 hemoglobin. This is where oxygen is reversibly bound to hemoglobin. It's getting ready to be released to the tissues. We have deoxyhemoglobin, or H hemoglobin. This is hemoglobin not bound to oxygen, but is capable of forming a bond when it's available. This would be the hemoglobin on its way back to the lungs. Carboxyhemoglobin is hemoglobin bound to carbon monoxide. As we're going to learn, carbon monoxide is very toxic and has 200 times the binding affinity to hemoglobin as oxygen does, so that's why it's so deadly. Methemoglobin is hemoglobin that's unable to bind to oxygen because the iron is in an oxidized rather than a reduced state. So that hemoglobin would not be able to take on oxygen. There are some different things that you're going to see on the blood gas printouts when you get to your clinical sites. The different quantities associated with assessing a patient's oxygen status are as follows. The oxygen saturation, sometimes called an O2 sat, is the ratio of oxygen bound to a carrier protein, hemoglobin, compared with the total amount of hemoglobin capable of binding. You'd like to stay as close to 100% oxygen saturation as possible. Then there's a fractional oxyhemoglobin, which is an FO2 hemoglobin. This is the ratio of the concentration of oxyhemoglobin to the concentration of total hemoglobin. Usually this is assessed by transcutaneous pulse oximetry. If you've ever been to the doctor and they put a little clip on your finger with a little red light on it, that is the transcutaneous pulse oximetry. Then we look at oxygen content. This is the total oxygen in the blood. It is the sum of oxygen bound to hemoglobin and the amount dissolved in the plasma, which is a PO2. Hemoglobin oxygen dissociation can be looked at too, depending on the situation that the body is in. Oxygen dissociates from the adult hemoglobin in a characteristic fashion in an S-shaped curve, as you can see from the picture to the right. The shape of the oxygen dissociation curve and affinity of hemoglobin for oxygen are affected by a few things. Hydrogen ion activity, CO2 and carbon monoxide levels, body temperature, and 2,3-diphosphoglycerate. That's a substance made in the red blood cells that controls the movement of oxygen from the red cells to the body's tissues. Well, here's what the picture shows on the top right. You see I have some comments down in the bottom. Shift right, won't hold tight. Shift left, no, won't let go. So if you have a situation that you see on the left with an increased pH, would be an alkalosis, a decreased CO2, which would probably put you in a respiratory alkalosis, decreased 2,3-DPG, and a decreased temperature, this could be a hypothermic patient, for example. And if it's shifted to the left, it's very difficult to bring the patient back to normal. On the right-hand side, if you have a decreased pH and increased CO2, with increased 2,3-DPG and an increased temperature, that's a shift right, won't hold tight, so it's a lot easier to recover from. Okay, so when we talk about the measurement of these different things, especially with oxygen saturation, we can use a spectrophotometric determination. The actual percent of oxyhemoglobin can be determined using a co-oximeter designed to measure various hemoglobin species. Each species has a characteristic absorbance curve. The number of wavelengths incorporated into the instrument determines the number of species that can be measured, from 4 to hundreds of them. We look at the four most common: H hemoglobin, O2 hemoglobin, carboxyhemoglobin, and methemoglobin. Some of the potential sources of error are faulty instrument calibration and spectral interfering substances, things that can cause like hemolysis or lipemia, things like that can cause problems. The blood gas analyzers actually measure pH, CO2, and PO2 with electrodes. They use amperometric, potentiometric, cathodes, anodes, and electrochemical cells for these types of measurements. The measurement of PO2 uses a Clark electrode, which measures the amount of current flow in the circuit related to the amount of O2 being reduced at the cathode. Some things that can cause problem with this are buildup of protein material on the surface of the membrane, which is why we have to run a cleaning agent through in between samples. We can also see bacterial contamination as well. Continuous measurements for PO2 are possible using transcutaneous electrodes placed directly on the skin. Then we have the measurement of pH and CO2. This is an ion force measurement that requires 2 electrodes and a voltmeter. A potential difference is related to the concentration of ion of interest by the Nernst equation. We do need to calibrate our blood gas analyzers very often. pH and blood gas measurements are extremely sensitive to temperature. The electrode sample chamber must be maintained at a very constant temperature. The pH electrode is calibrated with 2 buffer solutions, which is traceable to standards prepared by NIST. 2 gas mixtures are used to calibrate for CO2 and O2, and most instruments are self-calibrating and are programmed to indicate a calibration error if an electronic signal from an electrode is inconsistent with the programmed expected value. When I first worked in the laboratories, we had a lot of gas tanks and a lot of controls to run. Nowadays, there are actual packets that come that you place the whole packet in the analyzer and includes everything that's needed for all of these things. In addition to using electrodes and things for parameters, there are calculated parameters as well. The HCO2 is based on the Henderson-Hasselbalch equation and is calculated when the pH and PCO2 levels are known. The carbonic acid concentration can be calculated using the solubility coefficient of CO2 in plasma at 37 degrees. And the total carbon dioxide content is the bicarbonate plus the dissolved CO2 plus CO2 with proteins. In some cases, we do have to correct for temperature as well. By convention, pH, CO2, and O2 are all measured at 37 degrees. If a patient's body temperature differs from 37 degrees, blood gas instrument can correct those values. The results at 37 degrees should be reported too, however, just for reference. Quality control is very important. We have a lot of pre-analytical considerations along with some analytical assessments that we need to do. We need to make sure there's proper patient identification. We have to have the correct labeling of a specimen and accurate information provided. We have to have experienced, knowledgeable personnel. The specimens must be kept on ice to prevent a change in pH. There must not be any air bubbles. Air bubbles can cause a falsely increased oxygen and a falsely decreased CO2. Transport time is very important. We can't let them sit. We do need to run them immediately. The analytical assessments that we do are QC and proficiency testing. We use surrogate liquid control materials, tonometry, duplicate assays, and non-surrogate QC. And this concludes our section on blood gases.